All right, I'm going to talk about menopause and what is menopause? Well, actually, it just means the final period that we have. And we can't say that we've had our final period unless we've had 12 months without a period. It's a natural event, except for some women, it can occur because of treatment for cancer, either chemotherapy, radiotherapy, or surgery. And most women will reach menopause between the ages of about 48 and 55. Our average age in Caucasian communities is about 51. In some of the Asian communities, it might be a little bit earlier, in the late 40s. So this is a diagram that represents the sort of transition. So we go into what is called the perimenopause. That's the transition before our periods stop. And I'm going to talk a little bit about what actually happens to our hormones at that time. And this is a time where symptoms can start to present. And then once we get to the menopause, which is that final period, usually in the early 50s, and then we say we are post-menopause once we're 12 months after that final period. So we're post-menopause till stumps. There's no such thing as how long will my menopause last. Your menopause is that final period. So this is an interesting graph, but it does explain, and hopefully at the end of it you'll understand a little bit about the physiology of what happens during the perimenopause. So this is the final period, and these are years before the final period. The hormone secretions from our ovaries, particularly of estradiol, are controlled by a hormone in the brain called follicle-stimulating hormone. And that starts to slowly rise after about 35, very slowly, but then it starts to increase the rise in the last couple of years before the final period. And the reason for that is that it goes up because the ovary won't respond properly. So it increases the secretion to try and get the ovary to produce the estrogen. And so when the ovary says, I'm not really interested in listening to you, then it keeps pumping out more of the FSH. And then after that final period, you can see it rises dramatically, but it doesn't get to its peak until about 2 or 3 years after that final period. So there's a sort of gradual increase, and then it goes up, and then it stays up for the rest of our lives. But estrogen is a different kettle of fish, because you can see that there's some swinging here before we get to that final period. So it's a time where estrogen levels can be low, so women might present with some hot flushes and sweats at that time, but it also might be a time when in the next cycle the estrogen is up very high, and sometimes that's because we ovulate twice in a cycle, only in this time of our life. And when we ovulate twice in a cycle, the second time we ovulate in that cycle, the estrogen will go up extremely high. And when that second ovulation occurs, it often occurs during a period. And I'll talk a little bit about contraception in the perimenopause shortly. So basically, we have no idea where our estrogen levels are in that perimenopause, and it actually doesn't matter because there's nothing we can do about it. It's just how the ovary responds in the perimenopause. And that's very important because it's pointless asking your doctor to do blood tests in this particular phase. So what then happens is that around that final period, the estrogen level starts to diminish significantly. But once again, in this case, it reaches its lowest level about 2 to 3 years after the final period. So in this particular time, it's very important that if you have any bleeding in particular, and you think, oh, I'm having a period, but I can't be having a period because I'm menopausal, I've had my menopause, then you should really go and see your doctor, because any bleeding after that final period should be you should be seen by your doctor. So, measuring hormone levels in the perimenopause in most women who are presenting with symptoms is a waste of time. There is no test that will tell you when your final period will be. There is no test that will tell you that you're never going to have any bleeding. There is no test which will tell you whether you're going to have symptoms or not. And it's not necessarily going to help the perimenopause, the transition, by doing blood tests. So the only time we actually do use blood tests is when we're diagnosing a young woman with premature menopause before the age of 40. And sometimes, if women are not responding to hormone therapy, we may check their estrogen levels to see whether or not they're actually absorbing the estrogen properly. We would not routinely check estrogen levels on therapy, because what we're wanting to do is to see of a particular dose easing the symptoms. So once again, it's pointless doing the levels, because what might suit one woman will not suit another. So what about this perimenopause? Some interesting research done in the USA starting in about the 1930s. They took a group of young women and they asked them to chart their cycles. So on the first day of every period, they wrote down how many days it was. And so what this particular research showed was that the cycle was a bit chaotic for the first 2 or 3 years of a young woman's periods, and similarly it became chaotic at the other end in the perimenopause. And on an average, that irregularity of periods lasted about 4 to 6 years, but in some women it was as short as 1 and in others as long as 10. So these young women charted their whole cycle, every month for the whole of their reproductive years. Now, some women will not have any symptoms at all, but other women will start to feel different, to feel that there's a subtle or even a more dramatic change in how they're feeling. So what are those health changes? Well, obviously, fertility diminishes as we age. Towards the end of our reproductive years, our eggs age and they become less, the quality of them becomes poor. We develop cardiovascular changes. So some women will find they develop high blood pressure. We know that with the loss of estrogen at the time and around and after the menopause, total cholesterol will go up, our good cholesterol may go down, and our bad cholesterol will go up. And it's a time of transition for many women. It's a time of transition in terms of what's happening in the reproductive system. It's a time often socially and with family. So children we used to talk about the empty nest syndrome, now it's called the full house syndrome, and the boomerang children. And yesterday I saw a woman who was 55, menopausal, 3 children, all at home. The eldest one with 2 kids and a husband, the second one with 4 kids, and the young one, well, we think no kids. And so it's the boomerang time. So that creates a lot of stress and difficulty for women. And in that perimenopause, because of the irregularity of the production of hormones, we can feel irritable and cranky and not cope as well and fly off the handle a bit more and just not feel ourselves. And we know that where there is a history of any sort of psychological illness or depression or anxiety or bipolar disorder or schizophrenia, any of those conditions may be triggered to have another episode around the time of the menopause, because estrogen has a very important function in brain chemistry. So how do we manage the perimenopause? Well, it really depends on what the symptoms are. So women may present with bleeding, periods that are heavier, that are flooding, that are painful, and this may be new. They may present with menopause-like symptoms, they may present with premenstrual-like symptoms, and I'll just go through those symptoms shortly. So we may use a low-dose oral contraceptive pill if someone is not a smoker, is not overweight, has no risk factors for thrombosis, has no blood pressure. So someone who's fit and healthy, who also needs contraception, we may use a low-dose pill to control the periods and hopefully the symptoms. We may use a Mirena IUD, which will thin the lining of the uterus and reduce heavy menstrual bleeding, which I'm going to talk about a bit later on in the evening, and also will give contraception. And if contraception is not an issue, then we can actually use standard estrogen and progesterone HRT, but we would use it on a cyclic basis, so women would still menstruate. So, perimenopause, it's swinging, a swinging time. Estrogen swings between the very high and low, and as I've said, ovulation can take place twice in a menstrual cycle. So it is important to still consider contraception. The chances of getting pregnant obviously are very low as one gets towards reaching the final period. But there's some very interesting research that was done in the 1980s in New Zealand. And the researcher there showed that women could ovulate up till 3 months before that final period. And perhaps that double ovulation and the fact that we can ovulate right up till approximately that final period might be the cause of hearing, oh, well, mum had a menopause baby. And maybe it's because of that reason that we've found this out now, and that's the cause. So contraception should continue until the 12 months after the final menstrual period. If you're on the pill, you don't know. So that becomes a tricky diagnosis because we don't really know. And if a woman is under 50, we recommend contraception for 2 years after the final period. So just to give you a few percentages, there are about 20% of women who are very lucky, they stop their periods and nothing else happens. They don't have any symptoms at all. 60% of us will have mild to moderate symptoms, and about 20% of women will have severe symptoms that really impact on quality of life. So this is a lovely little graph that just shows us the interaction between the perimenopause and then postmenopause. So we can get symptoms of high estrogen, which could be sore breasts and some bloating, and maybe the change in estrogen going up and then going down, migraines and headaches, and the mood changes. And then the periods, because they're irregular, and they can be any sort of pattern, but we would consider that they were abnormal if women were having them more frequently than every 3 weeks. And then we've got the classic menopause symptoms of hot flushes and night sweats. And obviously, if you're waking up every few hours, you're going to have a sleep disturbance. And this is formication, not fornication. And it just means the ants under the skin. I'm sure many of you have had that experience where you go around scratching yourself and trying not to say, look, don't have head lice. So that's quite a common symptom. And we must remember that joint aches and pains are a very common menopause symptom. And some of the research done in Melbourne in the 90s showed that the percentage of women who had joint aches and pains, which began around the perimenopause transition, was up to nearly 50%. So it is a common symptom. And also being tired and irritable and just not feeling the same as you used to be, and perhaps not coping with life in the same way. Then there are some symptoms that actually don't disappear. The majority of symptoms will settle with time. Probably on an average or a mean, symptoms will last about 8 years, not the classic 5 which we're supposed to have them for, but probably about 8 years. And about 10% of women will have symptoms that go on for 10 years or more. We have what we call the urogenital symptoms, or the Americans have now coined it genitourinary syndrome of the menopause. They always complicate things, but in fact it actually is quite reasonable because it also brings into account sexual symptoms such as low libido and sexual changes in terms of sexual function. So vaginal dryness, loss of lubrication, discomfort with intercourse, going to the toilet more often, developing urge incontinence, suddenly key in the door, or turn the tap on really fast and you think, oh my God, I've got to go, and then you run. And the classic thing is you put the key in the door and you walk in and someone says, Mum, you said, don't speak to me, I have to go straight to the toilet. Don't even talk to me, I don't even want to speak. And also, sadly, things either tighten up or they sag. So some of us are saggers and some of us are tighteners. Mandy loves this cartoonist. Okay, and this is another one of Mandy's finds. So what can you do? What are the simple things you can do? Well, obviously you can dress in layers. I've got a few layers on tonight, I can tell you. And so you just peel them off as needed. It's really sort of empowerment, peeling them off, especially if you're in a meeting. Having a hand fan, or you can get all those little battery ones now. And one of my patients who had a history of breast cancer used to have one of those battery ones just on between the part of a steering wheel, just on the dashboard, so that it would just blow right in her face when she had a hot flush. And you can get these facial sprays, they're very good too, and also a cool drink. So there's simple things that women can do to try and ease a hot flush or sweat at a particular time. Also avoiding smoking, and there are certain other triggers like alcohol and coffee. Going into a heated room from a cold room, getting anxious or being embarrassed, that'll set off a flush in many women. Physical activity, well, you can sweat and enjoy your exercise if it's moderate, but if you get to high impact, it's not actually going to help the strength of your flushes or sweats at all. But moderate strength exercise is very good. And also looking after your mental health. So being able to, when you get tense and anxious, and Mandy's going to talk all about these things, relaxation, mindfulness therapy, and cognitive behavioural therapy. There is quite a bit of research now showing that these techniques can help the intensity and the duration of flushing and sweating. So what about HRT? Well, HRT means to replace the hormones that the ovaries are no longer producing, but it's primarily using estrogen. So estrogen is the hormone that has what we call receptors in many organs throughout the body. So when the loss of estrogen happens with the menopause, then many tissues in the body will slightly change their function, and the reproductive system and the vagina and bladder will change it more than some other ones. So we're replacing estrogen primarily. We're using progesterone in women who've not had a hysterectomy, so they still have the uterus, to protect the lining of the uterus. It does not have any other major role in HRT in the body. And testosterone we very occasionally use. particularly in women who have had their ovaries removed before they have reached the menopausal age. So we know, and we know from research back in the 70s, starting back in the 70s, that it is the most appropriate treatment for moderate to severe menopausal symptoms that impact on quality of life. And so it will help particularly the flushes and sweats, the vaginal dryness, and the discomfort with intercourse. It will definitely help those symptoms. It just depends on the type of therapy, the dosage, and the duration of it being given. And it is something that we have gone full circle with. From the 1990s, where it was often prescribed in ICUs for management of cardiovascular disease after women had had a heart attack and no longer thought to be appropriate, to treating osteoporosis, and then of course we had that big study that wasn't really about symptomatic menopausal women, and now we've come full circle and we've come back to the idea that taking hormone therapy is indicated for menopause symptoms, but at the same time in fit and healthy women it can reduce cardiovascular disease, and it will also act as a prevention for osteoporosis. So is it safe for me? Well, that is a very individual, it's very individual. We have to weigh up the risks and benefits for each individual woman. And so it depends on the intensity of symptoms and the duration and the impact on quality of life. They're the big things, and it's a very individual assessment. So for one woman, she may have what she thinks are severe symptoms, someone else might think are mild or moderate, but to her they impact on her quality of life. And none of us have any right to be judgmental about someone who chooses to take hormone therapy. It's not recommended in women who have a history of breast cancer, and it's not recommended in those women who have a history of heart attack or coronary heart disease, or have a history of thrombosis. However, we do, those of us who work in the special area of menopause, we do prescribe hormone therapy in all of those groups in special cases. So the latest literature says that HRT is safe for women who are fit and healthy, who don't have major risk factors if they are within 10 years of their final menstrual period or between the ages of 50 and 60. So what if a woman can't have hormone replacement therapy? Well, there are a number of medications that have been studied in research studies to see if they will reduce just flushes and sweating. And they belong to three groups. One is the antidepressants, the SSRIs and the SNRIs, and they will help not only obviously mood, but can also help flushing and sweating. However, one of the side effects of, in particular, the SNRIs are flushes and sweats. So we have to see what's happening with each individual woman. So the ones that we would commonly use is Effexor or Pristique, and the SSRI that we use at Monash as our first line is escitalopram. Gabapentin is a chronic pain medication and an anti-epileptic, and another member of the family is Lyrica, so they're very similar products, and they've been shown to be effective for flushes and sweats, and they will reduce flushing and sweating, including the intensity, up to about 60%. Clonidine is a very old medication. It's for blood pressure and also for migraine in some people, and it's effective in about 50% of women. So they're not as good as hormone therapy, but we use those, and sometimes we will use two of them together. Now, what about natural therapies? Well, there's not a lot of literature that's particularly positive in terms of them being better than placebo. There is A small amount of literature using phytoestrogens in the diet, so that's products like soy, the particular grasses, sort of alfalfa, those sorts of things, the legumes and many other, and the pulses. And they've all been shown to reduce mild symptoms, but you have to eat a lot of them. And we don't naturally have phytoestrogen, a high phytoestrogen diet compared to some of the Asian cultures. Herbal remedies, well, the one that's been studied most is black cohosh. There are two products on the market, Femula and Remifemin. Femula has some studies that have gone out to 12 months, and they're the longest ones. The Remifemin studies are much shorter, and they've shown with the Femula that a dose of 2 a day does seem to reduce flushing and sweating. Remifemin, perhaps with 4 a day. There's now a warning on the boxes of Remifemin because there were a number of people who developed liver failure, although the causation in terms of the black cohosh is thought to be not absolutely conclusive. There are some studies going on at the moment with meditation, yoga, and acupuncture, and some of these do show some help, but overall they're really reducing symptoms in a very mild way. The most important thing is to, if you wish to go down the natural therapy or complementary therapy way, is to actually seek a natural therapist who has an interest in women's health. So what about bioidenticals? And there's a question here already about natural hormone replacement therapy. Well, the question is, what is natural? And to me, the only thing that's really natural are the hormones that exist in the human body. And if they only exist in the human body, then there's no way we can actually get these products naturally, except to have them synthetically made in a laboratory. So bioidentical products that are compounded by a pharmacist are the basic estrogens, progesterone, testosterone, and whatever else is put in them, are all synthetically made. They have to be, because otherwise you'd be killing off a lot of women and taking their ovaries. And I don't really think that the pharmaceutical industry is really into that. They may be into other things, as we've been hearing about. And the bioidenticals, basic compounding products, are actually not registered with the TGA in the Department of Health. But there is a legal loophole that says if a doctor writes a script, then a pharmacy is legally able to dispense it. So there's no long-term research. It's just another form of HRT and no more natural than any other product. Every estrogen that we prescribe routinely now is estradiol, and that is a bioidentical estrogen. So what happens after the menopause? Well, I've said it either tightens up or narrows or sags, and the same thing happens. So we have to look after our heart, we have to look after our bones, and we have to look after our weight. Being overweight or obese will increase the intensity and strength of flushing and sweating, and often reducing weight will reduce the intensity of flushing and sweating. So we have to aim to try to reduce our risk of these chronic diseases which happen with the passage of time. So 50% of us are going to die of heart disease or cardiovascular disease. So we need to be looking at our lifestyle, we need to be looking at what we put in our mouths, and we need to be exercising. So don't forget, if you're experiencing menopause symptoms that are affecting your quality of life, please go and get some advice about it. Try and read up-to-date and effective information that is Dr. Google, we're going to hear about now, and hopefully that will give you some insight into how you should actually go through the web and not just pick up the first thing that comes up unless it's the Jean Hales website. So, thank you very much for your attention.